Hello, everyone. Welcome to today's webinar, Harnessing the Private Sector for Gender Equality. I'm Elizabeth Corley, Director of Communications for the Sustaining Health Outcomes Through the Private Sector Plus project with APT Associates. SHOPS Plus is USAID's flagship initiative in private sector health. This is the second in our series of end-of-project webinars, sharing lessons from over the life of the project. And today, we'd like to share with you how SHOPS Plus integrated gender into the project through global activities and in our country programs. This event will be recorded. We are recording now, and we plan to send all the registrants the recording next week. During the event, everyone will be muted, but we do want to hear from you. Please use the chat function to comment and ask questions. We'll have time at the end of the event to answer your questions. If you would like to adjust your audio connection, you can do so by clicking on the More Options button. Those are the three little dots at the bottom of your screen. And if you're having any technical difficulties, feel free to ask our host, Lauren Phillips Thorne, for support. Just use the chat function in the bottom right-hand corner of your screen. Now, let me introduce our moderator, Mary Beth Hastings. Mary Beth is SHOPS Plus Gender Liaison with Iris Group. She is a seasoned expert in gender and social inclusion with more than 20 years of professional and academic experience in sexual and reproductive health and human rights. Mary Beth?
Thanks so much, Elizabeth, and thanks to all of you for being here today. In today's webinar, we will highlight the integration of gender in the SHOPS Plus project. Gender integration in global health projects is critical to achieving desired health outcomes, as well as to pursuing gender equality. After all, gender norms and power dynamics affect health-seeking clients, health providers, and the organizations and facilities that provide services. Our three panelists will share how SHOPS Plus has responded to these norms and dynamics using the power of the private health sector. First, Dr. Hedayatullah Saleh will speak about work in Afghanistan to overcome gendered barriers to care at the client level by engaging men, including male gatekeepers. Dr. Saleh is a public health specialist with over 18 years of senior level program and project management experience in the private and public health sectors in Afghanistan. His areas of expertise include project management, project design, monitoring and evaluation, maternal and child health, health system strengthening, and urban health. He is currently serving as a consultant to the SHOPS Plus team in Afghanistan. Next, we'll hear from Maureen Ogada-Ndekana, who will share about efforts to build empowerment among women providers by expanding their access to loans and business training. Maureen is Chief of Party for SHOPS Plus Tanzania. She's an accomplished public health professional and accredited pharmacist with advanced qualifications in health management and sexual and reproductive health. In her career, she has focused on developing and implementing strategies that leverage private sector models aimed at solving health market challenges efficiently and sustainably. And finally, Dr. Maneshka Eliatambi will discuss how the project helped a social marketing organization in Nepal develop its internal capacity on gender. She is a senior associate at Iris Group, specializing in gender equality, public health, and social inclusion. For the SHOPS Plus project, she supported the Nepal CRS company in addressing gender, and she conducted a gender assessment for SHOPS Plus in Nigeria, as well as contributing to other activities. We will have questions and answers following the panel presentations. As Elizabeth said, please use the chat box to enter your questions. Before we begin with the panelists, I would like to introduce Joan Kraft, who is Senior Gender Advisor in the Office of Reproductive Health at USAID. She's going to make some opening comments for us today. Joan has over 20 years experience partnering with practitioners and researchers to develop and evaluate social and behavior change interventions for reproductive health. She provides technical assistance for the integration of gender into family planning programs with a focus on reproductive empowerment and intimate partner violence. Thank you so much for being with us today, Joan.
Thanks very much, Mary Beth, and welcome to everyone to this webinar. Before the panelists start, I'd like to take just a minute to talk about the context for the work that SHOPS Plus has been doing to address gender equality in the private sector. So across the Bureau for Global Health, we have 3 gender priorities. First, programs should empower people to improve their health. This may include improving educational and employment opportunities, including for women health workers, and increasing people's ability to participate in decisions about their health. That is, in decisions about things like health services, health systems, as well as decisions about their own health, whether or not to use contraception, whether or not to access antenatal care or HIV testing and care and treatment. A second priority is engaging men along with women to bring about gender equality and improved health. This includes engaging men in health care, both for their own health and for the health of their partners and their children. Finally, programs should work to prevent gender-based violence and respond to the needs of survivors. The SHOPS Plus project has been pushing boundaries and developing tools, models, and approaches for addressing these priorities in the private sector with the aim of improving access to and quality of services. We look forward to your questions about and reactions to this important body of work.
Thank you so much, Joan. I want to mention that Joan and the gender team in the Office of Reproductive Health at USAID have been tremendous thought partners and supporters throughout this project, and we're very grateful. They've particularly assisted us in integrating those 3 priorities into the SHOPS Plus project. Before our panelists give us specific examples and stories about why and how gender integration has been critical in this project, I will first set the context and the framework we used in SHOPS Plus. Form has been essential to the function of gender integration. And there are some important takeaways, I think, from the paths SHOPS Plus took to integrate gender across a global multi-year project. Next slide, please. First, an introduction to the project. As Elizabeth said, sustaining health outcomes through the Private Sector Plus project is the 6-year USAID flagship project on the private health sector. Its objective is to improve and sustain global health outcomes through public-private engagement, and it focuses on family planning, child health, TB, and HIV. From the start, SHOPS Plus was designed to achieve sectoral outcomes and advance gender equality, and gender integration has been essential for both. While we know that these health services improve the lives of women on their own, we also know that effective service delivery requires understanding, planning around, and where possible, transforming gender norms and power dynamics. As you'll hear, this includes what we typically think about in health service delivery, those interpersonal gender dynamics that clients face, but also barriers health providers face, as well as institutional gender challenges. Next slide, please. As you can see, over the life of the project, SHOPS Plus has had field offices around the world with activities primarily focused in 4 countries in Africa, 4 in Asia, and 2 in Latin America and the Caribbean. Our panelists will be highlighting work in Afghanistan, Nepal, and Tanzania. Next slide. Of course, gender integration doesn't just happen, and for SHOPS Plus, it was baked in from the start. This is a simplified version of the steps we took on the way to weaving gender throughout the project. I will walk us through these steps and provide some examples in the following slides. Next slide. The first and most important step was the development of the gender strategy. We conducted a project-wide gender analysis. We interviewed stakeholders and reviewed the literature. This allowed us to craft a process by which the project would integrate gender and initial benchmarks to measure our progress. The gender analysis was challenging across a global project, but it gave us a sense of the state of the evidence on issues related to gender in the private health sector. Next slide. So those big questions that we came across in our gender analysis, we found that the private health sector is largely unexplored and untapped on gender. The unanswered questions that we found were that there just didn't seem to be a lot of evidence or documentation on several of these. For example, at the client level, how well does the private sector serve women and men? Are there places where the private sector is serving women better than in the public sector? And why is that? Where are there gendered barriers to private health services? Are women who seek services in the private health sector also able to access gender-based violence screening and referral? At the provider level, do women who run their own practices face gender-related barriers to staying in business? At the organizational or institutional level, how much internal capacity do social marketing organizations, for example, have on gender? Are private sector facilities addressing the gender disparities that we know exist in the health workforce by incorporating gender intentional supervisory practices or policies? Next slide. The next step in gender integration was to build capacity through gender training and gender focal points. Next slide. Our capacity building efforts were designed to spread gender capacity throughout the project so that headquarters and field staff would understand the importance of gender integration to achieving their sectoral goals and would not need to rely solely on the experts in IRIS group to integrate gender. Gender focal points embedded in technical and regional teams allowed us to identify and implement opportunities for gender integration. We trained the gender focal points as well as gender trainers so they could in turn develop capacity among field staff and partners. Next slide. Building on that gender strategy and capacity, we were able to integrate gender into country activities as well as develop gender-focused initiatives with global implications. Next slide. At the country level, SHOPS Plus field offices, with the support, of course, of USAID missions, implemented a variety of gender-integrated activities. We trained health providers on gender in Nigeria and Madagascar. We built male engagement into programs in Nepal and, as you'll hear from Dr. Saleh, in Afghanistan. We raised awareness about reproductive coercion in India. As you'll hear from Dr. Eliatambi, we built a social marketing organization's internal capacity on gender in Nepal. And as gender is not just about women's access to care, we researched men's attitudes, behaviors, and their access to HIV care to lay the groundwork for a workplace pilot project in Tanzania. Next slide. To answer some of those big questions we uncovered in the gender strategy, we also were able to pursue several gender-focused activities with global implications. Two examples are pictured here, both focused on the empowerment of health providers. On the left, we developed a training module and counseling tool based on a conceptual framework theoretically linking gender transformative supportive supervision practices with improved provider retention and quality of care. This infographic analyzing gender barriers in health workplaces and the assessment of our activity are on the SHOPS Plus website. On the right, we explored how women owners of private health practices empower themselves when they have access to the right tools, including the technical skills, business training, access to finance, and links to insurance reimbursement that some social franchise networks provide and that are difficult to access, especially for women outside of those networks. Based on life history interviews with women providers, we were able to highlight the key inputs that they use to succeed as businesswomen while enacting their visions to meet vital health needs of their communities. These findings laid the groundwork for more focused economic empowerment work with women providers in Tanzania, as you'll hear about from Maureen. Next slide. By incorporating gender into our research, monitoring, and evaluation, SHOPS Plus was able to capture our results and important learnings. Next slide. The results we've captured show how gender integration has worked. Just for example, the project trained close to 1,800 health providers and local partner staff on gender and gender integration. More than half of new loan recipients in the last year have been women, and we helped partners shift their social and behavior change campaigns toward gender transformative messaging, for example, using both men and women in informational materials about child health care. Next slide. Gender integration in a 5-year global project has challenges, but the Shops Plus project provided important lessons, I think, for implementers in this space. First, engaging early is key with a project-wide gender analysis and a strategy outlining process and benchmarks. Next, gender focal points can bring their technical and regional expertise into gender integration processes while flagging opportunities to highlight gender within their teams. Leadership may be the most important, and a thanks again to the PRH gender team who helped us keep gender top of mind and supported our efforts to answer those big questions. Even with a project-wide gender analysis, country-level analyses are key to understanding and responding to local context and opportunities. Missions helped immensely in partnering with our field offices to pursue gender outcomes while moving the needle on sectoral gains as well. And finally, meaningful research, monitoring, and evaluation meant that we weren't just checking boxes. We were able to learn so much more about how we can most effectively harness the power of the private sector to advance gender equality and health outcomes. Next slide. Thanks so much. And now we're going to hear some terrific examples of field efforts on gender, starting with Dr. Saleh. Dr. Saleh, over to you.
Thank you, Mary Beth. Good morning. My name is Hedayatullah Saleh. I'm currently an independent consultant. I've had the opportunity of overseeing the Shops Plus project as the activity manager for the USAID Afghanistan mission. Today, I will be speaking from my experiences observing and overseeing the program when I was at USAID. Next slide. In Afghanistan, Shops Plus focuses on family planning and maternal and child health by supporting the Afghan Social Marketing Organization, or ASMO, aiming for increasing the sustained use of priority health products with particular emphasis on impact and efficiency. ASMO is the leading private sector provider of family planning and MCH products. Its contribution to national health outcomes is significant. In fact, the 2015 Afghanistan Demographic and Health Survey showed that close to a quarter of Afghan women were using ASMO's contraceptives and MCH products. ASMO uses a combination of commercial supply chain and in-house sales teams in order to distribute and sell products nationally through a network of over 2,500 outlets. In the slide, you can see ASMO's products on display in one of the pharmacies. Next slide. Gender dynamics. In a country at war for 4 decades and with a literacy level of 43%, will pose barriers. Here are some facts for you to ponder upon. The socio-cultural and economic contexts in Afghanistan are such that men are mostly the breadwinners, and therefore they're the ones who often decide the when, how, and where of healthcare for women in the family. There is a requirement for a male to physically accompany a woman when she leaves the house, which is called the mahram. And finally, myths and this perception that family planning is strictly forbidden or at least not desired in Islam is a huge factor. Next slide. Another reality. The vendors at the private sector pharmacies are almost always men, from whom purchasing by women of family planning products is complicated, with a lot of shame and embarrassment involved. There's evidence that tells us that 2/3 of women have a husband in the company when they come in for antenatal care. Now, that's a great opportunity if we counsel those men to help address the myths and misconceptions that they hold, yet that opportunity is often missed. And finally, there is the whole medical education system. My personal experience, as I was trained as a physician in Afghanistan, I hardly had the public health aspects of family planning and MCH included in our training. Now here, general practitioners, or the GPs, are the most visited category of doctors, particularly by men and more so in rural areas where specialists are few. Now GPs almost never provide any counseling on family planning, since they hardly have the necessary knowledge and skills and attitudes to do so. Next slide. So in light of what we just said, it's obvious that Afghan men need to be involved as supporters of women and their families and themselves as users of family planning services and products. In fact, a very recent study among married male adults across Afghanistan concluded that in order to secure the support of husbands and males to women, we needed to directly communicate with them and make them active partners, not just passive listeners. Next slide. So, how did SHOPS and ASMO approach this in broader terms? Well, first and foremost, there were things they could do in-house, or what we can call the ASMO operations. That included, among others, gender assessments, forming a gender committee, and ultimately achieving a gender balance within ASMO and its programs. Second, was addressing religious myths and misconceptions through behavior change interventions. And thirdly, there were a number of activities implemented in the private sector to promote spousal communication, eventually aiming for men to talk to their spouses or other women in the family and make joint decisions on contraception and birth spacing. Next slide. Now, speaking more specifically about male involvement, let me highlight key actions in the strategy. SHOPS Plus applied a funnel approach, tapping into multiple channels for reach and frequency, resulting in use of family planning and MCH products. To start with, mass contact for awareness and sensitization. Then, mosques for support from religious leaders and addressing cultural norms. And lastly, inclusion of the general practitioners in order to dispel myths and misconceptions of specific products and practices and generate use. Next slide. So let me spend the next few slides on those three interventions. As part of the mass contact, SHOPS Plus used national, regional, and local events, exhibitions, and fairs for building awareness of family planning and MCH among men. This slide and the next two slides show a few examples of those events. Next. 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 Imams, mosques, as we mentioned earlier. Imams from mosques, who are, by the way, highly respected at each community, have actively supported and engaged with resolving the religious myths. The initial stage of around 100 mosques and being able to reach out to over 24,000 individuals, majority of them men, were very well received by the relevant ministry within the Afghan government, and they advised for scale up to another 200 mosques and provided support letters to almost all mosques in the country. Next. Private providers. SHOPS Plus began by training around 115 GPs in the capital and then followed through by frequent visits by ASMO to those GP clinics so the message would be further reinforced. In the meantime, ASMO used that opportunity and sensitized patients and their accompanying family members as they would wait at the GP clinics. Next. So here are some statistics and numbers on what those interventions have meant in terms of reach. Over 1 million, 3/4 of them male, were reached through interpersonal social and behavior change interventions. Over 12 million through social media, more than 80% of them male. Around 50 million through mass media. And then around 577 private providers were trained, including the GPs that were already mentioned. Next. So a few key challenges that the program faced. Ongoing conflict, unfortunately, and poor governance exacerbate the problem of inequities in the country. Development programs, and particularly those that are focusing on MCH, have often ignored the role of private providers. Private providers are not sufficiently empowered to deal with social stigma and shame in order to engage in family planning counseling with their clients. And then finally, impact evaluation on end beneficiaries has been a challenge in this context. Next. Were there lessons learned in the process? Yes. To begin with, in-house buying and capacity is crucial, like in the case of asthma. Second, it's an effective strategy to primarily target entities and places where men gather and interact, for instance, mosques, and to build partners among influential people such as the imams. GPs provide an effective channel to reach out to couples and more directly to men. It's crucial to reinforce the messages and not do a one-off training. Like in this case, ASMO followed up after the initial training. Post-government, their buy-in helps tremendously set the stage and facilitate the work. And lastly, gender integration enhanced the effectiveness of ASMO's work tremendously. Next. This is a picture of the Shops and ASMO team based in Kabul, with whom I had the pleasure of partnering closely for almost 5 years. Thank you very much for your attention.
Thank you, Dr. Saleh, for presenting that important work. It just is clear that in such a challenging environment, addressing gender-related barriers at the individual level can make a big difference in access to family planning, although the road ahead is definitely difficult. Next, shifting to gender-related constraints at the health provider level, we'll turn to Maureen. Maureen, go ahead.
Thank you very much, Mary Beth. As introduced, I am Maureen Ogada-Ndekana, and I work with Apt Associates under the Shops Plus project in Tanzania. And today I will be highlighting strategies implemented by the project through our Banyan Global partners to support and foster women-owned health businesses for women economic empowerment. Next slide, please. Private health facilities in Tanzania, they play quite a critical role in women's empowerment, and that is through their offering of health services that are unique to women. And, these services include family planning services and maternal and reproductive health services. Tanzania, much like other developing countries, has a growing private health sector. And our private health sector has certain characteristics that I would like to highlight for the purposes of this conversation. So as referenced by the pyramid on the right of my screen, we have a small number of large private facilities at national and regional level. And these typically include private referral hospitals, faith-based facilities, and pharmacies. The private sector in Tanzania is also interestingly characterized by, a domination by a large number of smaller last mile private facilities in semi-urban and rural councils, as well as at village level. And these typically include drug shops and maternity homes. Next slide, please. So interestingly, in Tanzania, drug shops and maternity homes form the bulk of women-owned private health facilities. We have up to 80% of drug shops and up to 75% of maternity homes in the country that are owned by women. Something that particularly stands out about drug shops and maternity homes in Tanzania is that they are an important entry point into our health system for majority of our peri-urban and our rural women population who are seeking services, including family planning, child health, and maternal health. It is actually recorded that drug shops are an entry point into the health system for up to 75% of our rural population. Next slide, please. So let's talk a little bit about our approach and some of the strategies that we will be introducing later in the presentation. So once the project identified women-owned drug shops and maternity homes as private facilities of interest, we then embarked on a 4-step approach. Shops Plus started by applying the Women Economic Empowerment and Equity Gender Analysis, and this led to the identification of both financial as well as non-financial barriers and opportunities that impact women-owned maternity homes and drug shops in the country. Using the findings from this analysis, the project identified tailored evidence and recommendations to improve women economic empowerment through the private health sector. Finally, through the implementation of these recommendations and strategies, we continue to yield milestones that support women economic empowerment and improve health outcomes. Next slide, please. So from the application of the Women Economic Empowerment and Equity Analysis, we identified challenges and barriers that disproportionately affect women-owned drug shops and women-owned maternity homes. So we'll spend the next few minutes talking through what these results looked like. Next slide. From the results of the analysis conducted by Shops Plus, it is evident that limited access to finance impedes growth of women-owned private facilities and affects the quality of services offered by women-owned drug shops and women-owned maternity homes. You know, on the other side, traditional banks often don't meet the needs of women health business owners. And some of the reasons for this include the fact that banks typically have stringent collateral requirements and a complex credit analysis process, and this generates fear amongst women owners to approach banks for loans. Apart from that, we found that perception is an issue. Women owners of drug shops and maternity homes reported that credit facility interest rates are really high. We also recorded from the analysis perceived biases and discrimination by the financial sector towards women facility owners. And this is largely cultivated by the lack of trust, being that women, typically in Tanzania, own smaller health businesses, and these health businesses are typically located in more rural councils. And we also found that really there's just a general lack of familiarity of banks with lending to the private health sector. We also found that the credit analysis process is not considerate of the social, economic, and the cultural situations of women. For example, it is not considerate of the fact that women often lack full control of their assets, and also the fact that women will, more likely have more pressure to share their financial resources. So just to share an illustration of the impact of this scenario, when we looked at, data on loans to health facilities at one of our partner banks, we found that only 16.4% of the number of loans the bank was issuing through its various health portfolios were being made to women. And of the total loan amounts that the bank was lending, only 17.6 was going to women. Another finding that is worth highlighting from the analysis, more so for this conversation, is that we found that business training programs in Tanzania lack essential components such as coaching and mentoring, and they were also reported not to meet the gender-specific as well as health sector-specific needs of women-owned private health facilities. Next slide, please. So having considered, the barriers that disproportionately affect women-owned facilities, the project developed a tailored business training for maternity homes and financing products for drug shops and maternity homes. The next few slides will help us sort of talk through these tailored strategies. Next slide, please. So to bridge the barriers that women were facing in accessing business and financial management training, Shops Plus developed a holistic capacity development program to cater to self-identified needs of women, and we used women trainers to deliver this training content. So in terms of being solution-oriented, the training was delivered via WhatsApp, and this is because this is an application that the target audience had reported familiarity with. Therefore, there was ease of use amongst the women owners. Apart from that, the WhatsApp platform also allowed participants to access training content remotely. And, given the current COVID-19 restrictions, this definitely worked out perfectly. This also worked to an advantage of cost and time, and that is in comparison to typical in-person trainings. The training applied modalities such as group chat discussions in order to foster peer-to-peer learning and encourage exchange of ideas amongst participating women owners. Now, apart from the business and financial management modules, the business training was also adapted to include content that would be responsive to gender-specific and sector-specific business training needs of women health business owners. And how we did this is by introducing content or introducing modules that covered enabling environment, content on interpersonal factors that influence success, and content on the role of individual agency in strengthening business performance. Next slide, please. So on the other side, for a drug shop specific financing model, The project worked in partnership with the microfinance bank to design and implement an invoice financing product with a specialized approach specifically to financing drug shops. So what happened is that a three-pronged partnership was implemented, and the three partners included: one, Finca. Finca is a microfinance bank in Tanzania with regional branches across the country. Second was Nebula, a certified and registered pharmaceutical supplier of quality licensed medicines in the country. And the role of Nebula in the partnership was to offer negotiated volume rates by allowing networked drug shops to leverage pooled procurement. The third partner is the Association of Drug Shop Owners, and their role is to manage order logistics, to work with the bank to vet potential borrowers, and as well, when needed, to support in the debt recovery process. So the unique nature of this product made it, or makes it, continues to make it so much easier for women owners of drug shops to access credit, owing to the fact that, one, microfinance banks offers microloans, and therefore that is suited to these small facilities. The loan application process has been simplified, and most importantly, there's reduced collateral requirements. For example, in this model, the bank actually accepts, the inventory purchased using the loan as collateral, and this is as opposed to, the typical car logbooks or land titles that are often required. Finca, which is the microfinance bank, leverages in its regional branches in order to offer services and to reach drug shops that are in more rural districts. Next slide, please. So this talks, about maternity homes. So maternity homes are relatively larger than drug shops. So we needed to take a different approach other than the microloans. So maternity homes, we found that they typically need financing for equipment. So what the project did is that we partnered with a commercial bank to design a loan product for maternity homes. So the project, in partnership with the National Commercial Bank called CRDB, designed a pilot program to improve lending and also took into consideration strategies to address the financial institution's perceived gender bias and that had been reported through the analysis. This tailored product has a reinvigorated sales model that has, very specific features, including the fact that there's a female relationship manager or female relationship managers serving women owners, and, the fact that there are also reserved preferential interest rates for women-owned facilities and health enterprises. Next slide, please. So we have, some results that we'd like to share, as well as scale-up strategies from these initiatives. Next slide. 12 facilities have participated in the pilot WhatsApp business and financial management training. And we have gathered, learnings from this pilot program, and these learnings have been applied to adapt future trainings of this kind. In terms of a scale-up plan for training, the project is working in partnership with the Association of Midwives to target 100 networked maternity homes across Tanzania with the program. It is expected that by the end of this financial year, over 60 maternity home owners will have participated. We have also successfully leveraged on an innovative partnership. So working with an equipment supplier to subsidize training costs for midwives, we have managed to make the training more accessible to women health business owners. Next slide, please. On the invoice financing side, a strategy is in place to apply learnings to expand to 2 new regions. Apart from that, the pilot with the commercial bank recently commenced with up to 28 maternity homes found eligible to access credit. And the project expects that at least 10 of these maternity homes will be ready to move ahead and apply for the first round of financing. Next slide, please. So I'd like to end with a quote from a drug shop owner who participated in the business training and also benefited from the Finca credit facility in partnership with Nebula. So Gloria Macusa says, I am a member of the Pwani Ado Association, and as I mentioned earlier, ADOs are accredited drug dispensing outlets. By being an active member of the association, I have benefited from the business training that has improved my record keeping and from the inventory financing from Finca and Nebula Pharma supplier. I use the financing to increase my inventory, which has helped grow my sales. Gloria is a representation of women owners whose economic empowerment continues to improve from these initiatives, and in turn, enabling them to improve women's health outcomes through the health services they provide. Thank you, and I will pass it back to Mary Beth.
Thank you so much, Maureen. And just noting that our partner, Shops Plus partner, Banyan Global, has really formed a, they did a lot of this work, and so we want to acknowledge their excellent work on this. And I think it's just really interesting how women providers, as long as they have access to these critical tools for success, they empower themselves. We saw that in our work with women social franchisees as well. If they have access to the ability to purchase new diagnostic equipment or digitize their medical records, their businesses thrive, and that allows them to access those rural women that you mentioned at the beginning of your presentation, who are so hard to reach through other means. Now we're going to turn to Maneshka, who will share about institutional gender capacity building in Nepal. Maneshka, go ahead.
Thank you, Mary Beth. Namaste and welcome to the section on building gender capacity at Nepal CRS Company. Next slide, please. Nepal CRS Company is a social marketing organization with over 40 plus years of experience. They are major contributors to family planning in Nepal. They're also the lead on the USAID funded Gaon Gaon Mein Swasthya project, under which the Rural Area Initiative falls. The Rural Area Initiative, or RAI as we call it, was a project between 2016 and 2020, which worked to increase zinc for childhood diarrhea, delivering babies in health facilities, hand washing, and birth spacing. Next slide, please. It is important to acknowledge the role that the leadership of Nepal CRS Company played in integrating gender within the organization and in their programming. This quote from Jiblal Pokhrel, who is the managing director of Nepal CRS, really sums up the way in which they collaborated in gender integration. He says, integrating gender is important to the efficacy of our programs and the well-being of our staff and organization. It is also important to acknowledge the very forward-looking strategies, the gender and equality and social inclusion strategy that Nepal in itself has. Between 2007 and 2015, Nepal established a very robust gender equality and social inclusion strategy, which includes men, women, and gender minorities. And this was a first in South Asia. Next slide, please. In 2017, IRIS Group carried out a gender assessment, and that was done under Shops Plus, under the Shops Plus umbrella. We carried out semi-structured interviews with key stakeholders, including staff and key partners and board members. The assessment sought to assess the technical capacity, political will, internal policies and processes, and the culture related to gender at the organization. We also reviewed internal documents and project reports. Next slide, please. This assessment laid the foundation for gender integration at Nepal CRS. This was both internal facing as well as outward facing. Internally, Nepal CRS focused on staff capacity building, establishing of gender focal persons, as well as including gender sensitive language. We'll go into a little bit more detail on each of these issues as we move forward. Next slide, please. With regards to staff capacity building, IRIS Group under Shops Plus carried out staff training on gender inclusion to 82 of the staff. At the time, there were 66 males and 20 women. It's important to note that there is much greater gender balance in the company now, attesting to the more gender-sensitive hiring practices that are being implemented. The objective training was to prioritize institutional gender mainstreaming and also programmatic gender integration. Next slide, please. Nepal CRS and Shops Plus leadership in Nepal, including Jiblal Pokhrel and Jeff Barnes, who was the chief of party in Nepal, jointly decided to develop a gender focal person structure at Nepal CRS company. They jointly identified several potential gender focal persons, each of them representing their core departments at CRS. And they provide technical support during development and implementation of programs. This is the group of gender focal persons you can see in this picture, along with some of CRS leadership and Shops Plus leadership. Next slide, please. To celebrate some of the achievements that the gender focal persons managed to achieve over the last few years, we'll look at both internal as well as outward-facing achievements. Internally, the Nepal CRS GFPs or gender focal persons conduct trainings to new staff who are coming in on gender integration. So all new staff receive gender integration training. Announcements of vacancies are now gender sensitive. Previously, the announcements had read the position is open to and it would say things like he or she is encouraged to apply. And we realized that this was actually slightly in violation of Nepal's GESI policy. And so now we encourage those from gender minorities also to apply for jobs. Also internally, established a menstrual hygiene sanitary disposal system, first at CRS headquarters and then also at field offices. Next slide, please. External facing achievements include engaging male groups and husbands groups in the rural area initiative. In RAI 1, there were very few opportunities to engage men and husbands, and there was a concerted effort that was made in RAI 2 to engage men and husbands and fathers. We even developed a sub-program titled Hamro Bacha, which means our child, which celebrates the role that both women and men play in child rearing. Nepal CRS has gone on to establish a menstrual hygiene management education program in schools for both female and male students in the Far West, which is just taking off. And also, Nepal CRS made a recommendation to USAID to include gender minorities in the A-Tracker Plus system. This was important because in Nepal, we recognize males, females, and gender minorities, and we were not previously able to capture the work that we had done with gender minorities. And so this change to the A-Tracker Plus system has enabled us to holistically capture everything that is done at Nepal CRS. Next slide, please. This is a quote from one of our gender focal persons, and it really underscores the importance of the work and the sustainability of including gender in programming as well as within the organization, beyond the Shops Plus engagement as well. Shreya says, to bring change for gender equality in an organization and its activities, it has to start within. The gender focal persons at Nepal CRS company are the key staff members for ensuring success of CRS gender mainstreaming program at the organization and in projects that we implement. Next slide, please. So there were several lessons learned, and we've captured a few here. One of the most important lessons is that it was important for us to use the assessment to identify gaps and to build capacity and to also create internal support. Here, I want to stop for a moment and really talk about the internal support that we received, not only from the top leadership at Nepal CRS, but also from the leadership within all of the departments. If we did not have support from the leadership in the departments, the gender focal system also would not have worked as well. And so it's very important that the leadership is also on board with engaging gender. The next was that GSPs translate gender capacity into programmatic results, and we have seen this over the last few years and look forward to seeing the progress. And then also, gender integration needs to be both inward and outward facing. And you can see from some of the lessons, some of the takeaways from our Shops Plus engagement that the integration of gender was both inward facing and outward facing. Next slide, please. So this is the group of gender focal persons along with Nepal CRS leadership as well as Shops Plus leadership. We look forward to your questions.
Thank you so much, Maneshka. You closed with such an important lesson that institutions that look inwardly and address gender-related barriers inside their organization are much better poised at success for integrating gender externally. And not only that, they're better ambassadors for gender integration as they are cleaning their own houses first. As the panelists captured, integrating gender in the private sector presents some daunting challenges. You generally have to work with many more actors who aren't governed by a central authority, so there's not an easy way to mandate addressing gender. At the same time, there are tremendous opportunities in integrating gender in the private health sector precisely because it works. By eliminating the disparities and power differentials related to gender, you build markets for family planning, you help health providers succeed, and you ensure that health-related businesses are creating gender equitable environments for their employees, and in turn, improving their ability to deliver more equitable programs. So now we're going to move on to questions and answers. And I encourage you, if you have not already, to add some questions to the chat. I see that we have several already. There was a question from one of our participants about Afghanistan and about the materials for imams on family planning and whether they were available to other implementing partners and available in multiple local languages. Dr. Saleh, do you want to respond to that question?
Sure, Meredith. Yeah, the materials, I think on the chat box, we already responded. Thank you, Sumitra. They're developed in accordance with the ministry's guidelines and in partnership with another USAID program. They're available in both languages, Dari and Pashto.
Great, thank you so much. Maureen, there was a question about whether there is what it is about the health sector that presents women entrepreneurs with challenges as opposed to, for example, agriculture or other sectors. Do you have any comments about what might set the health sector apart?
Could you please repeat that again, Mary Beth?
Sure. There was a question about what specifically about the health sector presents challenges to women entrepreneurs as opposed to agriculture or other sectors, or are the challenges the same?
Thank you, Mary Beth. I'll start off and then I'll pass this on to my colleague Ignacio to also make some comments. So particularly, Mary Beth, I would say geographically, I think maybe this is a good way to look at it in Tanzania. So generally, women-owned businesses in more, located in more rural councils in Tanzania do, more or less face similar challenges, especially when it comes to access to finance. Some of the reasons being, number one, they're typically smaller businesses. Number two, the challenge of collateral really is across the board. As I mentioned in my presentation, one of the characteristics of women here is in Tanzania is that they typically do not have full control of their assets. So whether it's a woman, who owns an agricultural business in rural Tanzania, or a woman who owns a health business in rural Tanzania, these will typically be, the same challenges. I don't know if Ignacio knows if there are any sort of, differences when it comes to urban-owned businesses by women, but I generally say that, the challenges are the same. They're not quite any difference. The only difference that might be there, Mary Beth, is the fact that the banking sector or the financing sector might have a little bit more experience lending to the agricultural sector as compared to the health sector in Tanzania. So that is where a few differences might be. Thank you. Ignacio, if you have any additional comments.
Thank you, Maureen.
Maureen,
Ignacio?
Yeah, hi. Maureen, I think you're right on. I mean, the big one is that when we're just looking at the women's business owners, is that the agricultural sector, financial institutions do tend to understand that sector and have lending programs for that space, both government programs and private sector programs. And the other thing I would say is that the autos, the drug shops, and maternity homes that we dealt with tend to be less formal institutions, so even more complicated for banks to deal with, which is part of the reason why we chose Finca Microfinance in our project with the drug shops.
Great, thank you, Ignacio. And I would just add that what we found in our work on the social franchisees is that many of these health providers didn't see themselves as business people, and I think that challenge is even higher for women health providers, because they went into this to provide a service to their community because they saw the need in their community, and so to then switch to thinking of themselves as business persons in a culture where maybe women are not regarded as business people is an additional challenge, I think. All right, so we've gotten some great questions. There was a question about, and I want to put this out to Mineshka first, and then others if they want to respond, because we're short on time. If you have seen any specific threat on gender equity in your respective countries due to COVID-19. Go ahead, Mineshka.
Sure. One of the issues that we faced in Nepal, especially, and I think across the board, is that a lot of females, especially who are in the informal work industries, so housemaids and such, are really unable to access products as a result of losing work during COVID. And then there's also been difficulty accessing products as a result of lockdowns. So those are two ways that gender equality and gender equity have been affected with regards to.
Great, thank you, Mineshka. Others, anybody else want to chime in on this? All right, great. Well, we will leave that there. I think there were some answers in the chat as well. But since we are nearing the top of the hour, I'm just going to close this off with a few words. But I want to give a big thanks to our panelists for their expertise today. And thank you to Joan Kraft, and thank you to all who came to participate today. Please check out the Shops Plus website for more details and stories. In closing, as was demonstrated by our terrific panelists, the building blocks for gender integration, gender analysis and assessments, gender capacity building, gender integrated monitoring and evaluation can and should be applied throughout global health, including in the private sector. We are so grateful to USAID and its partners for their commitment to this, and for recognizing that while gender integration may be hard and may take resources, it's urgent, it's necessary, and it's a boost to every intervention and approach because it helps create meaningful change in people's lives. At Shops Plus, we are proud to have pioneered gender integration in this space, capturing the power of the private health sector to improve gender equality. Thank you so much, and have a great rest of your day.